Welcome to today's episode of Medically Speaking. Today I have a great guest with us, Dr. Brian Goodman. Brian is one of our thoracic surgeons here at Self Regional, and we have a great conversation today that I look forward to having. So we'll just start with, Brian, why don't you just tell me a little bit about yourself and your background? And
Sure. I grew up in South Florida,
Okay.
and from there headed north. Went to medical school in Vermont. I guess at the time I was really into skiing. I don't know. Spent some time in the north. After completing medical school, I did residency at Allegheny General in Pittsburgh. Then I did a cardiothoracic surgery fellowship at The Ohio State University. And from there, I had kind of the luck of being invited to Harvard, where I did clinical fellowships in minimally invasive thoracic surgery and thoracic surgical oncology at the Brigham and Women's Hospital. And so then after I finished my training, I worked at Geisinger in Pennsylvania and WVU in West Virginia before getting tired of the snow and coming back home, coming back down south. And I've been at Self Regional for about 3.5 years, and it's been pretty awesome.
Well, Brian, listen, you have really built a great reputation for yourself here in this community, and I hear often stories from patients where you've really made a difference in their lives, and we're certainly glad that you're here in Greenwood and serving the community here. One of the neat things that you brought here, maybe we can just talk about this for a minute, is our approach at Self Regional to lung cancer, and specifically the pulmonary nodule clinic that you started when you first moved here. Why don't you tell us a little bit about the pulmonary nodule clinic and the types of cases that you see here,
Sure.
And a little bit about your practice.
Sure. So as far as my practice goes, thoracic surgery is a specialty that deals with essentially the treatment of non-cardiac, both benign and malignant diseases of the chest. And that includes lung, esophagus, chest wall, mediastinum, which is the central compartment of the chest, and the diaphragm. Lung cancer is probably the overwhelming focus of my practice. And when I arrived here, one of the problems or kind of issues that was facing the community was that there were kind of all of these pulmonary nodules that were being found and being sent all over the place. And pulmonary nodules are really pretty common. About actually 50% of people over the age of 50 will have them. 95% of the time, they're benign. They're nothing to worry about. Living in the South, actually, the way that I'll talk to patients about it is it's kind of like everybody knows how to deal with moles or things on your skin, right? And
Right.
so, if it's a tiny mole and it's been there forever, you're like, oh man, that's just a mole. But if it, everybody knows all the criteria. If it catches your eye, you get it looked at and you make sure. So most moles are not skin cancer. Well, most nodules are not lung cancer. So it's not a perfect correlation, but I think it kind of makes sense to people because that's just part of living in the South. And the problem is these things show up all the time. It's estimated that about 30% of imaging studies that are performed that image the chest will find a pulmonary nodule. And given that there are literally, upwards of like 4 to 5 million chest imaging studies done a year, you're talking about over 1 million incidental lung nodules. And so it becomes very cumbersome in kind of trying to figure out, how to manage these, particularly if you don't do it all the time. Physicians are just looking at a report or a study, and it says, there's the pulmonary nodule, and then what size matters. Some of these, as imaging technology has gotten better, we can spot things that are 1 and 2 millimeters. I mean, we're talking the thickness of a credit card or two that have almost no clinical significance up to sizes that do matter. And although there are algorithms and guidelines for this, it's cumbersome, particularly for physicians who are already juggling tons of other patient-related data. And so we figured out that kind of a central clearinghouse and a central area of expertise that could actually take these things from diagnosis or finding them, all the way to we're done with them. This is what, this is kind of what needs to be done, either, once or twice and then done, or ongoing following it. And so that's been, I think, really successful, because it's kind of one-stop shopping. Doing it, kind of managing this as a surgeon, the majority of these are not surgical issues, but the nice thing is I can own it completely in my practice, can do everything that needs to be done without having to refer a patient to anyone else. And through relationships that I have in the kind of cancer treatment pathway with, pathology, medical and radiation oncology, and interventional radiology, when something does need to happen, it happens very quickly. And so we've really seen a lot of success with that. Some of the data that we've reviewed has actually shown that with increased rates of surveillance, and this kind of gets more into screening than actually the pulmonary nodule clinic, that you can just do more and find more earlier. And so the pulmonary nodule clinic is essentially doing that by serendipity, because these are incidentally found nodules that were imaged elsewhere. But what we really want to push for is to continue, obviously, seeing these patients with incidentally discovered nodules, but what we really want to go after are these patients who meet high-risk criteria and get them screened so that we can get them in.
Great points. So that kind of leads me to my next question, is around lung cancer screening specifically. And so what are the current guidelines for lung cancer screening? Who should be screened? Who should be considered at a higher risk and should be getting checked out?
Absolutely. The risk factors of the definition of high risk have been actually kind of reevaluated, but basically age is probably the most important thing. And so generally we look at people age 50 is kind of what the criteria said, but in these parts, a lot of people will actually start smoking much earlier than that. And so it takes, we think, 30 years of kind of ongoing, 20 to 30 years of ongoing tobacco use. And so, although the criteria for high risk state age of, 45, if you started smoking at 12, you could absolutely have, 20 to 25 years of constant smoking by the age of 35. And so I think there's a slightly broader definition of high risk here, but as far as the actual, the way that it's defined by the studies and the criteria is age greater than 45 to 50 with 20 years of regular tobacco use. We kind of at one point said, well, what does that mean? And we use pack years as a definition. So if you smoke a pack a day for 20 years, that's a 20 pack year history. If you smoke 2 packs a day for 10 years, that's a 20 pack year history, the same thing. Now, a lot of people will, when you ask them about it, they'll kind of nickel and dime you, well, technically for 3 years I was really smoking only 7 cigarettes a day, but we try to encourage people to round up. We're not keeping track of this. You're not going to get scolded. We really would much rather overestimate your risk and your exposure than underestimate it. And for those people who are identified as quote unquote high risk, and so just to summarize that, that's age 45 or greater with 20 years of smoking history. It's recommended that they get a non-contrast lung cancer screening CT. And this is a low dose scan, but very kind of high resolution. And these scans are able to pick up very, very small nodules and really lung cancer is very easy to find, because it's generally greater than a certain size. We think that 8 millimeters, which is just slightly larger than 1/4 of an inch, is kind of the cutoff. And that's very, very easy to see. What kind of complicates things sometimes when we find the smaller things that you can't really tell what they are yet, but then you just kind of follow them. And once you know something's there, following it is easy. It's just there are plenty of people who have never been imaged, and so that's what we really want to try to focus on. But for high-risk people, getting them in and getting them screened is super easy. I mean, it's literally about 30 seconds of time in the scanner. It's covered by insurance, and it's kind of an in and out thing. And we know that in populations that are screened, the incidence or the detection of lung cancer at an earlier stage is much higher. In kind of multiple studies that were done, they showed very clearly that there was up to 25% increase in diagnosis at early stage. And when we talk about early stage lung cancer, we talk about lung cancer with survival exceeding 60%, whereas advanced stage lung cancer, long-term survival is around 7%. And so the numbers are so bad at the later stages. That's why when you combine them all together, take all comers, overall, 5-year survival for lung cancer is reported at about 25% still. We're making significant improvements. There's been an improvement of probably over 20% in the survival rates in the last 5 to 10 years, with the more and more both screening and just incidentally finding things because people get imaged now more often. But
so if you have a 20-pack year history of smoking cigarettes and you are over 45 years old, you should get screened for lung cancer. And the screening test is a non-contrasted CT scan. And just for the audience, that requires no IV, no pain at all. You literally just lay down on the table and they take pictures.
That's correct.
And then you get up and you go home.
That's correct.
And then you get a report back. So it's a very simple screening, much less invasive than like colon cancer screening where you have to get a colonoscopy and a whole day out of work and all that. You literally can come in on your lunch break, get a quick CT and go home.
Absolutely.
Yeah, so it's quick and painless screening.
Not to take anything away from screening for other cancers, because obviously that's really important in things like mammography and colon cancer screening and colonoscopy, right? But to put things in perspective, those are kind of much more uncomfortable screening tools, but they're utilized pretty significantly. Yeah. Overall screening rates for high-risk populations for lung cancer nationally, 5 to 6%.
For people that meet criteria.
For people that meet criteria.
Wow.
And
way under-screened.
Well, and here's the most striking thing. The number of patients needed to be screened to save a life in the high-risk lung cancer population is about 360. It is by far the lowest of any cancer screening. So the impact of lung cancer screening is greater than the impact of screening for basically like breast cancer, colon cancer, and anything else combined, but utilization is really low. So there's such an opportunity for impact if we can get the word out.
Wow, I think that's really meaningful. So, and I'm just going to say that back too. So for every 360 people that meet those criteria of being over 45 with a 20-pack year history, for every 360 people that get a screen, you'll find a lung cancer.
That's correct.
And potentially save a life.
Correct.
Big deal. That's a big deal that we push this and really get screening out there. Brian, can you tell me a little bit more about, say, your involvement in our cancer committee? Let's just talk through that process for a minute. So a lot of people don't know how that works. So if you were diagnosed with cancer, we have such a phenomenal cancer program and cancer team here that a lot of people probably don't know about. Tell us a little bit about your involvement on our cancer committee. And like say, if you were to say do an imaging or you were referred a screening case and you found a lung cancer, like what's the planning process for treatment for that cancer right here in Greenwood? And talk about a little bit of the advanced care that we provide.
Absolutely. So Self-Regional is part of the American College of Surgeons community cancer program. And that's a pretty rigorous accreditation process where you have to meet, strict criteria. And for the cancer committee here, I function as the cancer liaison physician. And so I'm in charge of basically all the kind of quality control measures and reviewing kind of how we perform in comparison to regional and national benchmarks. And so there are, very strict criteria for kind of who we have available, services we have available, how we basically see, screen, and process patients, the time in which it takes, and the way things kind of move through according to both national guidelines and the most current and most state-of-the-art treatments. And Self Regional has done a great job of doing this, kind of on their own, but with the oversight of the American College of Surgeons as a designated, cancer center. We have, this is not just kind of marketing where we say, yeah, we do this or that. There's, strict criteria, and only certain places do it. And so one of the things that or kind of the way that we look at things is how do we perform as far as, time from initial presentation to diagnosis, and then from diagnosis to first course of treatment. And we're actually constantly looking at this in a rolling fashion. And one of my roles is to be, I'm constantly reviewing data, and I have to report back to the hospital, the committee, and the American College of Surgeons quarterly on this. And we're consistently meeting guidelines for this, or exceeding them, both, regionally and nationally. But in general, if someone presents, like to kind of walk through it, someone gets sent to me in the pulmonary nodule clinic. They have what appears to be a suspicious looking nodule. They come to see me in the clinic. We review the imaging studies together, and that's really important to me to always, put the scans up on the screen and explain to the patients exactly what's going on, and kind of, make sure that they leave knowing what I know. And we review that, and then if it looks suspicious, because a lot of times at this time all we have is an imaging study, and that's one of the things where I think we really excel, is rather than saying, well, let's watch it, maybe we need to get a PET scan, maybe we need to do this, maybe we don't, with 20 years of experience, knowing a patient's history and being able to look at something, I can say, I think there's a real good chance this is a cancer, and rather than kind of guess about it or hope, let's just move forward. And so we can very quickly, pretty much and very often on the first meeting, get everything set up with biopsy, PET scan, pulmonary function testing, if they're a surgical candidate, determine all of these things, and then, within a week, 10 days, have everything set up and have all that information. Once we have all that information, the patient is then presented at it's called Multidisciplinary Thoracic Tumor Board, and that's a weekly discussion with pretty much all of the stakeholders who are involved in cancer care and the complete spectrum of cancer care. So it's surgeons, radiation oncologists, medical oncologists, pathology, radiology, nurse navigators, social work, palliative care, basically everyone that could possibly play a role. And we discuss each individual case, discussing, national guidelines and what the best way to proceed is for this individual patient. So each decision for treatment is tailored to the specific patient. So if you are 70 years old and have pretty severe lung disease and are already oxygen dependent and do not have a lot of physiologic reserve, then we're going to come up with a treatment that involves probably stereotactic radiation, right? Which is a kind of very straightforward, easy to tolerate treatment. And we're very fortunate here at Self Regional to have quite literally one of the most advanced, linear accelerators for stereotactic radiation available in the world. And so that's just amazing that we have that. And so if that's the route, we get that sorted out and give those recommendations, and then discuss with patients and their family and come to a decision. If we think that someone is a better candidate for surgery and can be, have their cancer completely resected and with curative intent with surgery, and we'll present that as our recommendation for them. And if so, then usually within just a few weeks, we'll get everything, all the required preoperative testing and lung function and everything done, go through the details of the surgery with the patient, they want to proceed, we get them to the OR and get it done.
Yeah. So, I mean, honestly, the multidisciplinary tumor board to me is one of, like, it's just awesome. You have you as an individual, you've got radiation oncology, medical oncology, a thoracic surgeon, for specific to lung cancer, other types of cancers have the specific specialist that's involved in that care. But to me, there's no better way to do it. You have all the players, like you said, in one room looking at that one individual patient and tailoring the treatment to that patient's specific cancer. To me, it can't get any better than that. And to have such high qualified, medical staff like yourself and the others you mentioned, it in a community our size is really phenomenal. And I'm very grateful you're here, Brian, and the work that you're doing is amazing. And I know over the last several years we've really had some significant improvements in our care of lung cancer patients. I thought maybe we could talk about that for just a second, and kind of how do we do at Self Regional? If you look at like national statistics and like how are we doing in Greenwood with treatment of lung cancer specifically, or whatever like cancers in
Absolutely.
general?
As I mentioned earlier, as the cancer liaison physician for the American College of Surgeons here, I have to look at this stuff, and we're constantly being evaluated on it. And it's kind of a point of pride for us, because not only are we meeting regional and national standards, we're exceeding them. We're literally, outperforming, much larger centers that have much larger budgets and much more with regard to resources. So time from initial presentation to first course of treatment, we're outperforming national centers. And we are consistently meeting criteria for breast cancer, colon cancer, and lung cancer, which all have kind of the most specific recommendations, and kind of are the keys to accreditation as really kind of the most commonly encountered cancers, but the ones that also have kind of the most data of how things should be done. And so if you compare, the treatment of breast cancer or lung cancer at Self Regional to, you pick the market or the institution.
Big academic centers all over the country.
So compared to MUSC in Charleston, compared to Duke, compared to Emory, we meet or exceed the performance of those institutions, and will provide, quite literally the same exact care. And from a thoracic surgery standpoint, the neat thing is it's a pretty small community nationally. And, so pretty much all of us know each other, and particularly in the Southeast region. And so if someone ever does have a concern and wants to, get set up to go see someone at Emory or Charleston or go to Duke, it's an easy phone call, because we kind of all know each other. And most of the time, I can count on one hand the number of times that someone has wanted to do that since I've been here, because honestly, I think there's just so much information available now that, everybody kind of goes home and, if they don't find it themselves, they talk to their kids and they're like, oh, we looked up this and that. And, that looks like that's what you would get pretty much anywhere. But, the handful of times that I have had people go elsewhere, they came back and said, well, we were told they would do the same exact thing. And it would make sense to just have it done right here in Greenwood, which for me, that's awesome.
Yeah.
I saw that, so when I was in Boston, people came from all over the world to get care there. Particularly because there is a kind of a very strong focus on treating, a couple particular cancers there. And so for that reason, they came from elsewhere. But a lot of times they would come and have their surgery, and then we would talk with their oncology team at home and go over everything with them, and kind of post-op care and everything. But the traveling and everything it's just so cumbersome, and so that was one of the things that was really attractive for me in coming here, was being able to do that kind of stuff here, in Greenwood, to see the insight that Self Regional and the board and the people who kind of think about these things, they realized that there was a real need for this in the region. And it's very satisfying for me to be able to offer this kind of world-class care that you may have thought you needed to travel someplace else to go get right here. And that pretty much keeps a smile on my face every day. I mean, it's very satisfying.
That's awesome. Well, you're doing a great job. And like I say, we certainly feel fortunate to have a Harvard Fellowship trained thoracic surgeon right here in Greenwood, South Carolina.
That's one of those things that
awesome.
you don't like,
Yeah.
I don't make a fuss about that.
No,
particularly.
I know you don't. You don't brag on yourself. I appreciate your humility as well. But it is awesome to have that level of expertise and training right here in Greenwood, and to be able to offer your skill set to the community for folks that need it. I did want to just maybe change the subject just a little bit. So we've talked about lung cancer screening and kind of who meets the criteria. When we think about kind of looking at lung cancer kind of through a health equity lens, just for a second, I know you've been involved in our Health Equity Advisory Task Force. And can you talk about that for just a minute, the Health Equity Task Force, and also specific to lung cancer and disparities nationally around perhaps different races maybe not getting the same level of screening or treatments as others, and then specifically how are we handling that in Greenwood?
Absolutely. I think that the Health Equity Task Force is a great initiative that Self Regional has undertaken, kind of with an awareness of kind of our community, and trying to address specific issues that may have been kind of either less obvious or just kind of raise awareness to things. And so, particularly here where we have a large African American population, there are certain issues that really, contribute to kind of increased both morbidity and mortality in Black communities. And really interestingly for me, is tobacco use contributes actually to the 3 leading causes of death among Black Americans, and so cardiovascular disease, stroke, and cancer. And it really disproportionately affects the Black community. One of the most striking things statistics I've seen is that tobacco kills more African Americans each year than AIDS, alcohol, car accidents, drugs, murder, and suicide combined. That's how significant these disease processes are in the Black community. And it's interesting because even though African Americans generally actually smoke less than non-African American smokers, they have higher rates of death from smoking-related disease. And so the thinking on this is an issue with access to care or access to screening, kind of medical literacy and education, and things that we probably can move the needle on. And so making sure that we do something to increase community education about this, improve access to screening and care, make it easier for people in our community to get in and get to see someone, make it easy for them to get on medications and get titrated, make it easier for them if they want to quit smoking to get access to things that can help them. Because the data is very clear that these things are really kind of not taken advantage of as much. And so we, as a whole, as an organization, there are other issues as well, but obviously this one is very near and dear to me. So the Health Advisory Task Force is really trying to focus on, what can we do to improve disparities in care that really have a significant effect on our community. And we're, like I said, hoping to, with initiatives, kind of improve access that over time will help avoid some of this basically excess mortality.
Brian, so if one of our viewers feels like they meet criteria for needing lung cancer screening.
Mm-hmm.
In other words, again, just as a summary, it sounds like over 45 with a 20-pack year history of smoking cigarettes.
That's correct.
How do they go about getting a screening test?
The easiest way is probably just to ask their primary care practitioner to go ahead and refer them for that. And once the screening test is done, if there's no findings, that really, doesn't really need to go any further. And if there is anything that needs to be looked at, then they'd most likely be sent to me for review.
Good.
And if they don't have a primary care provider, they can certainly just contact the thoracic surgery office, 725-7900, and would gladly help them get it set up.
Perfect. Brian, thanks for being with me today
It's my pleasure.
Telling the audience about your practice, thoracic surgery, cancer care in Greenwood in general, and specific to lung cancer and lung cancer screening, and a little bit on healthcare disparities. So appreciate your time today. Thanks
Thank you
for joining us.
Thank you for having me.
Absolutely.